You're listening to Conferences on Lyme Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 24th, 2023. Our topic today, atopic dermatitis, part of our orientation series. Our presenters are yours truly, Dr. J. Portnoy and Dr. Aarti Pandya. We're in the section of allergy, asthma, and immunology at Children's Mercy Hospital in Kansas City, Missouri.
Good morning, everyone. Welcome to Conferences on Lyme and Allergy, coming to you from Children's Mercy Hospital in Kansas City. It is July 24th. We're continuing with our orientation series where we have Dr. J. Portnoy and Dr. Aarti Pandya, who are taking on the first kind of 8 important topics in allergy, although there are many more. And today they will be talking first about atopic dermatitis, and the second presentation will be on food allergies. Thank you for being here.
Great, thank you, Chris, and welcome everybody to our next presentation on cola. I'm going to go ahead and share my slides so that you can see the presentation. Let's see, share. Here we go. Do you see the slides?
Yes.
So, as you know, as you can see, our first presentation is on atopic dermatitis. I'm dressed the way I am because I'm going to go see the Barbie movie later today, so it should be lots of fun. But in the meantime, we're going to have fun with atopic dermatitis, otherwise known as eczema. So let me just move forward. These are our disclosures. These are the learning objectives. And I guess we're going to start out by just figuring out whether individuals have eczema or not, and maybe you can tell me what you think about this, Dr. Pandya. Here's an 8-month-old who gets peanut butter on their arms and hands, and shortly afterwards develops a blotchy red rash where it touched. The rash lasts for several hours and then goes away. Is that eczema?
This sounds less like eczema, Dr. Portnoy. The time duration of resolution, the characteristics of the rash don't really match the pattern of atopic dermatitis.
Yeah, it's actually pretty common for especially younger babies to get a rash where food touches their skin, and especially on their face, spaghetti face, that kind of stuff. It's really common, and yet parents see the rash and they think, oh, there must be an allergy. It's not an allergy. What about a 6-month-old who's told to wash their hands frequently? Now they have a rough, itchy rash on the back of their hands. What's that?
So, yeah, that's a great question. And it kind of puts a little bit of an asterisk on how we define eczema in terms of whether we're talking about atopic dermatitis or an eczematous rash. This could be an eczematous rash, but this doesn't sound quite like atopic dermatitis.
Okay, so atopic dermatitis is a subset of eczema. Eczema is more a generic term describing an eczematous looking rash.
Yep.
What about a 12-year-old who has bumps on the back of their upper arms? It's not itchy, but the bumps are noticeable. I have a lot of parents who come in with their 12-year-olds wondering if that's eczema. What do you think?
Yeah, that sounds less like eczema as well, Dr. Portnoy, kind of describing maybe a keratosis pilaris rash.
AP, yeah, that's very common, but a lot of people, especially parents, don't know that it's not eczema. They think it is. 3-year-old gets a slightly itchy, rough circular rash in the middle of their abdomen that is persistent. What's that?
Yeah, again, that could be, like you mentioned, a type of eczema, but not the subset of atopic dermatitis.
Yeah, when I see a rough circular rash in the middle of the abdomen, I think of a contact dermatitis from nickel on the blue jeans snap. Just something to keep in mind as a possibility. A 4-month-old with rough, very itchy skin over a large portion of their body with scalp flaking. What's that? Sounds awful.
Yeah, I think that there is a possibility that could be atopic dermatitis.
Yeah, sure sounds like it. A 3-year-old has rough, itchy skin on their neck and the intercubital and popliteal fossae during the winter.
definitely sounds like potentially atopic dermatitis.
And I couldn't have actually put a more characteristic description of atopic dermatitis if I wanted to. Exactly. So do you want to do you want to go
Yeah.
through the history and what parents usually
Yeah.
complain of?
Definitely. So this speaks to two things. Firstly, with regards to eczema or let's call it atopic dermatitis, there's not necessarily one, and I think this is mentioned later in the presentation, there's not one, you know, diagnostic test that you can do to diagnose these patients. This is a kind of a clinical diagnosis. So it generally starts with, a good history with the patient. Mainly from that starts from this chief complaint. So generally, in a child under 6 months of age, you'll have a complaint of a bad rash, possible allergies. Now we know that this diagnosis can be characterized as different things by different providers, and oftentimes, especially if the rash is not going away, parents will believe that this is a food-induced process. So they may come to you in the clinic thinking, "Oh, I actually am just here for food allergy testing because I have this terrible rash that doesn't go away." So we'll talk during this presentation about, how that's kind of not generally how atopic dermatitis behaves. Um, and then this last point here that the rash gets better with treatment, but when the treatment it stops, it causes frustration. So atopic dermatitis is a relapsing condition that can kind of come and go over time. The last point also speaks to in individuals who have atopic dermatitis, it's important to have both a treatment plan as well as a maintenance plan. So oftentimes when they come to you with this last complaint, they won't have a good maintenance plan that's been prescribed, which can result in more widespread eczema, which can result in concerns about, oh, I have food allergies, etc. But it's more important to manage the rash correctly.
This is a common comment that parents will often make, and I think it's because they have a misunderstanding. They think that it's like poison ivy. If you treat it, it goes away and then it's cured. And they don't realize that eczema is a chronic disease. The creams don't cure it, they just control it. And I think it's important right up front to tell them that so that they're not surprised that it comes back when they stop the treatment. It's not curable, it's just treatable. So what are the essential features? What things must be present for it to be called atopic dermatitis? You want to do that?
Yeah, definitely. So generally, atopic dermatitis is known to be a very pruritic rash. So this can occur both during active disease when the patient has, active erythematous, eczematous lesions on their body, or it can also occur, when in areas where the skin is not yet diseased as well. Generally, though, they're very itchy. And then the age-specific patterns will differ kind of based on whether they're a young infant or older patient. And I think we have a picture about that comes up a little bit later. But we know that, yeah. And then lastly, it is a relapsing disease that can occur, meaning the rash can kind of come and go over time. It's generally, although there are a small subset of individuals who can, put on an emollient and the rash goes away, the majority of them will have rash that comes back over time.
Yeah, and parents bring their kids in for lots of rashes. If it's not itchy, it's not eczema. I think that's a good rule of thumb. Eczema is always itchy. Now, there's some important features that support the diagnosis, but don't necessarily have to be present. I mean, frequently there's an early age of onset, but it doesn't have to be early onset. And often there's a concomitant atopy, either a personal or family history. They may have IgE reactivity, but again, atopy is not required for a diagnosis of atopic dermatitis, even though the name atopic dermatitis has the word atopic in it. It's not required. The other thing is that the skin is not always dry, though it usually is. And if it's dry, that does support the diagnosis. But these are some other associated features. They're non-specific, but they suggest that the patient may have atopic dermatitis. Did you want to discuss these?
Sure, yeah. So kind of going through all of these with the regards to the vascular responses, of course, you can have facial pallor, erythema, delayed blanch responses. With regards to the second point here that says keratosis pilaris, pityriasis alba, ichthyosis, they do have features that kind of overlap with eczema, but again, these are some different diagnoses from eczema. With, or I should say, atopic dermatitis. With atopic dermatitis, you can get some ocular periorbital changes as well as complications from that. So, and that's especially in individuals who have severe atopic dermatitis, where you want to monitor that. And then with regards to regional findings, it looks like we have perioral changes and periauricular lesions, though they definitely can happen in those areas. And then with prurigo lichenification, those are also complications of atopic dermatitis as well.
I'm afraid that some of the new allergy fellows might not be familiar with some of these terms. These are kind of dermatology terms, and when I look at them, I wasn't always familiar with them either. So I actually included some pictures of what are these terms anyway. You know, white dermographism is shown on the left, and when you scratch it, rather than welting up like you would in regular dermographism, the skin turns white. Usually turns red if it's not eczema. Keratosis pilaris is just these little bumps on the back of your arms usually. It's caused by a buildup of keratin around hair follicles. So it's called pilaris, means hair follicles. And then this hyperlinearity, we've all seen that. We just didn't know what to call it. If you see somebody whose hands look like that, which is very common, that suggests that they have atopic dermatitis. Lichenification, we've seen that too. This is just a chronic condition. If they scratch the itchy part over and over and over again, the skin thickens and eventually it becomes this kind of rough, thickened area, lichenification. The prurigo is these little bumps and they become very itchy after scratching. It's basically from scratching a lot. And if you scratch your skin a lot, even if you don't have eczema, you will eventually develop this. It's very common in the wintertime when people's skin is dry. And then ichthyosis, that's just a really bad part of atopic dermatitis when it's progressed particularly far. So these are terms you can use to describe what the skin looks like when patients come in to see you. Do you want to describe the different types of eczema?
Yeah, and I think we were referring to some of these on the earlier slides as well, or in the earlier vignettes. So let's go to the very top one that says atopic dermatitis. So this is presuming that the patient is a little bit older. They can get a distribution in the flexural areas, including in the popliteal fossas, in the antecubital fossas. Generally, when you have that with a lot of the features that Dr. Portnoy described on the last couple of slides, you think about atopic dermatitis. Dyshydrotic eczema is essentially where, the hands, because of being rubbed together for whatever reason, hand washing, etc., can result in an eczematous type of rash. But generally, this is just limited to the areas where the skin is like being rubbed together. Contact dermatitis, this is when individuals are exposed either to an irritant or an allergen that they can develop an erythematous, but also vesicular papular rash. And generally, the time duration for this is much shorter than atopic dermatitis. We know that atopic dermatitis is chronic long-term disease, whereas with contact dermatitis, it generally initiates in times where when you're in contact with the irritant or allergen.
And the most common contact allergen is nickel.
Yeah. I think, it's been historically nickel, and I think we are seeing the prevalence of some additional allergens increase, like things like fragrances, et cetera, that have been on the rise from personal care products. Neurodermatitis, Dr. Portnoy, do you want to talk about that one? I could talk about the remainder.
Well, if you just keep scratching in one area because you have a sense of itch, and then that can cause the changes in the skin that look like atopic dermatitis, but it's not actually the same disease.
Yeah.
And I think the bottom line, nummular dermatitis is just the little round patches, like nummulous little clouds. Seborrheic dermatitis, the skin's more oily and it's in the scalp and around the nose and the eyelids and things like that. So there are different distributions. But as we said at the beginning of this discussion, eczema is a description of the way the skin looks. It's not a specific disease, and in that respect, it's a more generic term. And then within eczema, or each of these different specific diseases. Contact dermatitis is a specific disease we're not talking about today. Atopic dermatitis is just one of the diseases that can cause eczematous-looking skin. And, you know, we talked about the age-related distribution. It's very typical in young infants. It tends to be more widespread. It's on the chest, the abdomen, the whole legs, the whole arms, but it's really the extensor surfaces. And then as they get older, it moves around to the flexor surfaces, the popliteal and what is the other one called?
Popliteal and the antecubital fossas.
Antecubital fossa, and then the neck and the hands. And there's specific places where you tend to see it.
Definitely. And you talking about the extensor surfaces also when you're thinking about a younger, an infant who's not yet walking, remember they're crawling on their arms and on their knees. And so that's why kind of the extensor surfaces tend to get affected more during that time period. But in general, like he said, that's generally the pattern when they're younger, which changes as they get older.
So I always ask, how long has it been present? Does it vary over time? In most cases, it starts soon after birth and then it gets worse. In an older child, I ask if the rash is getting better because it starts off really bad. And then after a few years, it starts to improve. And that the blue line, which is the eczema line, kind of illustrates that. They call it the atopic march because once the eczema starts to get better, that's when you develop the food allergy and then the nasal allergies and then the asthma. And it's just kind of the natural history is that these things occur sequentially.
But Dr. Portnoy, we need to Photoshop out the cane for the 70-year-old.
Say what?
We need to get rid of the cane that's for the 70-year-old.
Oh, no. I'm almost 70. I don't have a cane.
Yeah,
so
exactly. We need to Photoshop that out.
That's a stereotype. It's not real. Is there a seasonal pattern? Eczema is usually worse during the winter. The air is cold and dry, but it may get worse in the summer if there's extreme heat, because heat and cold can make it worse. But some parents, here's what I found is interesting. There's a lot of psychology involved in atopic dermatitis. In general, it's not an allergic disease. Allergies are not the trigger. Actually, atopic dermatitis causes food allergy. It's not caused by food allergy. But some parents insist that you do allergy testing. And I only put this statement here because psychologically, some of them won't answer you until you first tell them, yes, I will do testing. They're afraid that you won't test, and they came to you specifically to have a test. It's weird. I mean, it's what people want. And so if that seems to be in the way, they keep asking about the testing, then I stop and say, I will test you. Just relax. The testing will happen, but first, I need to ask you some questions that might help figure out what tests to order. And that usually calms them down, and then they're willing to answer the question. Have you run into that?
Yeah, that's a great point that you bring up, Dr. Portnoy. And I think it comes from a couple of different places. One, obviously misconceptions, the media, et cetera. And then secondly, perhaps they've been battling with the disease without effective treatment for so long that they just, quote unquote, want an answer. And they think that a singular test is going to, stop the rash and cause a magical remission of their disease. And so it requires a lot of counseling. And generally when I, approach these patients, because you never know what kind of testing you may need to do for an atopic dermatitis patient. If they look actively infected in the clinic, you may need to do a test to make sure that they don't have a secondary infection. If it's a very, very young infant presenting with very widespread severe eczema, potentially with other things going on, you may need to do an inborn error immunity workup. So the testing may vary from the individual. So I do take a similar approach that you do. I kind of start off the visit saying, hi, my name is, I know we're here to talk about, this rash you've been having. We're going to talk about it. And then afterwards, I'll talk about any testing that we'll be doing and then the treatment options. So that right off the bat, at least they've heard that and they're not stuck on that during the visit.
Because they're afraid you won't test them. And usually they want an allergy test. They don't really think of those other things, even though we do. Intratriginous skin. I love that word. I use it all the time, and people are just amazed that I can say the word. It's a very interesting word. It just means skin folds. It's the site where opposing skin surfaces come into contact while at rest, resulting in skin occlusion. It's caused by skin-to-skin friction that's intensified by heat and moisture. The primary intratriginous skin areas include groin folds, axilla, gluteal cleft, as well as antecubital fossa and popliteal fossa. So the reason that the eczema occurs where it occurs is because those are the intratriginous areas. It's a great word to remember. People are impressed that you know how to say it. It's hard to say sometimes. You always ask about triggers for eczema, and you get the following replies. And I don't know if you've seen parents say this or not, but they say numerous foods because they're really focused on foods. And it seems to make it worse. I just can't figure out which ones. I can't identify a food that triggers it, but I know there's one. Or they might say there's no obvious trigger. What responses do you get?
Yeah, I think if it's the food thing can be quite frustrating to from their end as well as from your end, because you know that they're trying to maybe get at a point of being pan tested for all these different foods, which you know is just going to put them at a significant risk. And then they are probably stuck on that again because of all these either misconceptions, frustration due to the lack of responsive treatment. So sometimes they do get stuck on it. But I have had some patients where I'm able to kind of identify if there's a clear seasonal pattern of worsening of their atopic dermatitis. Sometimes the atopic dermatitis gets worse around pets, or if they use a product that has fragrances, dyes, parabens. So sometimes I will, pick up that, but the food thing can be quite frustrating from both ends to work through in the
I think
clinic.
they believe that if you can identify one food like milk, and they stop drinking milk, the eczema will go away.
Right.
It doesn't work that way. Even if they avoid milk, the eczema is not going to go away.
Yes, exactly.
I ask about emollients that have or are currently being used. Now, most people don't have any idea what an emollient is. We'll talk about it in a moment, so it's better to just call it a moisturizer. Most families have something, they just don't know what it is. They bought it at the drugstore. And to avoid represcribing an ineffective treatment, I always ask if any treatment they've tried helped, because if it didn't help, then either it wasn't the right treatment or it was used incorrectly or something else. I also ask about other treatments, and I don't expect them to have done these or know what they are, but some families have heard of wet wraps and they use it. Others are kind of puzzled by the question. If they don't know what that is, they haven't used it. Same thing with bleach baths. Parents, when I ask about that, usually have a look of horror because they envision pouring bleach on the skin. I assure them we're not pouring bleach on their skin. We're basically recreating swimming pool water in their bathtub. And if you phrase it that way, they calm down and are not so horrified by the very concept. There's lots of emollients. Do you want to discuss some of these real quick?
Of course. So there's so many different types of emollients. The major types include, creams, ointments, lotions, as well as gels. And so how these are characterized kind of depends on the content of oil and water that's within the individual emollient that you're using. Generally, with creams, as our slide says here, they're equal parts oil and water, easily absorbed. They can cover large areas of skin. They don't leave behind kind of that greasy feeling, so patients do tend to like this as an emollient option. However, we know that ointments, in contrast, which is the second point here, they contain a much higher oil content, about 80% oil compared to water content. So this is very thick, almost very like viscous in nature. However, it works really well for helping kind of rehydrate a very dehydrated skin. And then if we can go to the next slide here, lotions. So generally these work well for combination or normal skin and doesn't need the oil content. So this one is going to have, again, lower oil content compared to what an emollient does. And then a gel, it contains cellulose, water as well as alcohol, and it provides hydration. It doesn't leave that kind of viscous feeling on the skin, but the skin may absorb the gel quickly, that no moisture barrier remains. So that may be one thing you need to think about when contrasting the four options.
Now, this tells you when you would use each of these different things. There's also a thing called balms, which is not usually used in atopic dermatitis. And when you go to prescribe your emollients, your formulary on your computer will list these different kinds, and it's just helpful to know which ones are which, and then make an informed choice about what to recommend for that particular patient. So I think this is a helpful table. Before I start into treatment, this is just my own personal approach to eczema, atopic dermatitis. Most parents want to know, what is eczema? And when I ask them, do you know what eczema is? They look puzzled. Nobody's ever told them. They have no clue. They've just been told it's eczema and here's what you do about it. And most of them really want to know what it is. They want to know why their child has eczema. And saying things like it's a skin disease or an inflammatory process or something, that really doesn't satisfy them. Most parents want you to tell them a story. And I'm a big fan of telling parents stories. Whether it's completely true or not, it's pretty true. It's close enough. I tell them that eczema is a genetic condition. It's caused by a mutation in filaggrin. Filaggrin is a gene. It creates a moisture barrier on the skin. I know not all eczema is caused by filaggrin, but it kind of gives them a sense of what kind of disease it is and helps them to visualize what's going on. So I think it's a worthwhile thing to tell them, even if you don't have a gene test proving that in that particular person, filaggrin's the cause. I tell them that if filaggrin's defective, the moisture evaporates out of the skin, it dries out. This causes the skin to itch, which leads to scratching, which leads to inflammation, which causes more itching, and it becomes a vicious cycle. I also tell them that allergies do not cause eczema. And in fact, in reality, eczema causes allergies because your skin's porous, it absorbs allergens through the skin, and that's why you develop food allergy sensitization, because you're absorbing food allergens through the skin. That's why kids can react on the first ingestion. What do you think about telling people a story, Dr. Pandya?
Absolutely, Dr. Portnoy. I think, a lot of them also will come to you thinking that, they come to you with almost this guilt, like, man, either I can't get my skin clear, and then there's like psychological implications with that, or I can't get my child's skin clear, so I must be doing something wrong. So I take that guilt right out of their hands right off the bat. I say, hey, this is a chronic condition. It's not something you're giving your child or that your child is doing. This is something that they were born with. And then we know kind of like the atopic, molecules and things like that may result in long-term, having skin disease. But I take that kind of guilt out of their hands and say, hey, this is something that, is a chronic disease that we need to do a treatment phase and a maintenance phase for. And we have a lot of different treatment options to get there. It's not one thing you're doing that's resulting in the child's eczema or your eczema.
Yeah. And again, filaggrin can be your friend if you tell them about it.
Yeah.
It's the itch-scratch cycle. We don't have to spend time on this, but the skin barrier is damaged. You get the irritants enter. There's inflammation, itch, scratch. It's a vicious cycle. Do you ever do the EASY score?
Absolutely, Dr. Portnoy. The EASY score is an excellent tool that we can do for individuals who have atopic dermatitis. I believe the score differs a little bit if you have a pediatric patient versus an adult patient. So age is one of the things that differentiates, how the score looks like. But we take into account a couple of things when we calculate this. Firstly, it's a validated scoring system we use in individuals who have the diagnosis of atopic dermatitis. We can use it to track their disease long-term, visit to visit. Sometimes also if you're going for advanced therapies for somebody who has atopic dermatitis, you may need to know what the EASY score is for insurance purposes. But beyond that, it's a tool we know, like I say, it's validated, that we can track. And the components of this include knowing the areas of the body, the extent of eczema or the extent of these four things in those particular areas, which include erythema, papular areas or edema, excoriation, and lichenification. So you calculate the body surface area that's involved with atopic dermatitis, or that's affected, I should say, not with, that's affected. And then you write out these individual things. And then you have to kind of add them all together to kind of get a final score. There are some online calculators too that you can use for EASY.
Yeah, this is the formula. I would recommend that you use an online calculator because the math can be a little bit confusing. I personally use a spreadsheet that's been developed, so it does the math for me. And then in the end, you interpret it as, clear, almost clear, mild, moderate, severe, or very severe. Why would you do an easy score? It helps you monitor the eczema over time to see whether your treatment is effective, what's getting better or worse. And the other reason is that if you want to apply for a biologic like Dupixent, most health plans require an easy score, and the score has to be 21.1 or greater, proving that it's severe eczema. It's amazing how many of my patients have an easy score of just a little over 21. It just happens. I don't know why. No reason. How often should somebody bathe? What do you think? What do you recommend?
This question comes up every couple of years, and the recommendations change for this every couple of years. So initially we were told, more frequent bathing can cause harm to the patient. It can kind of wipe off skin layers, so we don't want to do that. Then we hear, well, not bathing enough can kind of cause more difficult to treat eczema or atopic dermatitis. So the recommendations for that, like I say, periodically change over the years. And so generally I do talk to them about, if possible, bathing once a day, but it depends on the individual family. What do you think, Dr. Portnoy?
Yeah, I mean, not everybody can do it every day. That can sometimes be too much. But if they were told don't bathe very often and they're intentionally withholding baths that their child might enjoy, I tell them frequent bathing is okay. More frequent, better. I tell them to do a soaking bath till the fingers are wrinkly, and then immediately afterwards put an emollient or a moisturizer to the skin while it's still wet to keep it from drying out. If you do that, it's not going to dry out like they believed in the past. Do you ever recommend bleach baths?
I have, especially, for decolonization purposes. Like you had kind of mentioned earlier in the talk, some of this requires just reorienting them about what a bleach bath is, ensuring them that we're not pouring bleach on them or anything like that, that we're actually putting a small amount of, amount of that in a bathtub full of, lukewarm water, and then doing a soak in there for about 5-10 minutes or so. And then after that, making sure a good moisturizer goes on the skin as well.
So somehow, to me, it seems like a more appealing approach than antibiotics, which are more specific to particular bacteria and lead to antibiotic resistance. I don't know of any bleach-resistant bacteria. Oh, by the way, if during summer they can be encouraged to go swimming in a chlorine swimming pool, that might do the same thing. It's important to be safe, though. You don't want the kids to get the bleach in their eyes or swallow it or anything like that. Don't drink the bleach. It's not good for you. It doesn't kill COVID either. What about wet wraps? Do you ever recommend those?
Yeah, I definitely have. Wet wraps can be done either with just an emollient or with a mild steroid. Generally, we don't use medications beyond that. We don't use more potent steroids. We don't use calcineurin inhibitors or anything like that, prostaglandin inhibitors when we're doing this. But the concept essentially is that you have a patient who, let's say they've taken a bath, they've patted their skin dry. You take some type of clothing and you run it under warm water and then kind of wring out the clothing for any excess water. You put some type of barrier on the patient, like I said, either a mild steroid or it can just be the emollient itself, and then you cover it with that wet layer and then put a second warm, dry layer on top. You can leave it on for several hours. You can leave it on overnight, and it kind of helps a lot with the hydration component of the skin.
Yeah, I found that it works particularly good on extremities like hands and arms and legs and feet. You can take like a tube sock and cut the bottom out so it's just a tube and use that. That's a very easy and convenient type of a wet wrap. And they want to leave it on for at least several hours. It kind of drives the emollient into the skin and helps to moisturize it. Okay, topical steroids. There's a lot of information about steroids and a lot of confusion. First of all, we have to consider the potency. For sensitive skin, you want to use relatively lower potency. If you're going to put it on the face, you want to use really low potency because the face is a very sensitive area. And of course, intratriginous skin, there's that word again. I love that word. If you have the trunk and extremities are affected in a medium, I don't recall ever prescribing a high potency steroid to kids, but if they have severely lichenified skin, sometimes that's what it takes to penetrate through the severely thickened skin. The side effects, with occasional use or periodic use isn't too bad, but it becomes greater likelihood of side effects with long-term use. And some of these include stria, skin atrophy, telangiectasia, acne, bruising. In children, if you use widespread steroids and as opposed to just on this certain little parts of the body, they may also absorb enough to have HPA suppression. Have you ever seen that?
So, I don't know that I've seen that directly just from topical steroid use, but we do know in our patients who are atopic, they often have coexisting atopic disorders that require steroids given topically, intranasally, inhaled. And so, there is, of course, information out there about how that needs to be monitored long term in individuals, and something just we need to be cognizant about in our atopic patients in general.
Yeah, because they can combine together to give you a cumulative thing. I guess I never measure HPA suppression, so how would I know if they have it?
Correct. Yeah.
Okay, there's different steroids. There's low potency, medium potency, and high potency. These are just a few examples. To me, it's very confusing. There's just too many to choose from. There's nobody who knows, well, at least there are probably very few people who know all of these steroids. What I recommend is just become familiar with one or two from each group and use those. Usually it's the ones that the health plans reliably approve. You agree?
Yeah, definitely. And another point to mention that Dr. Portnoy mentioned, generally, the use of high potency topical steroids in atopic dermatitis is we generally don't do that long term in these individuals. There are certain rashes where you need that long term, but not atopic dermatitis. Generally, we stick to medium potency for the body, low potency for sensitive areas.
Exactly. What about topical calcineurin inhibitors? There's basically two that I'm familiar with. There's tacrolimus or Protopic and pimecrolimus or Elidel. They're both approved for moderate to severe or mild to moderate atopic dermatitis. Protopic is approved for adults, but there's also a lower potency preparation for children less than 2 years of age. With the Elidel, it's 1% for age above 2, but they don't have an indication for under 2. I'm not sure that it would be illegal to use it in such kids. The reason I would use a topical calcineurin inhibitor is because you can avoid steroid side effects. So transient application may cause some burning and stinging. It's pretty common, but if they can get over that and the skin can heal, then that usually gets better. And for Elidel, at least there was a black box warning. I don't know if that's been removed or not. It doesn't seem to have been borne out, but for a while everybody was afraid to prescribe Elidel because of this warning that rats get cancer or something. But it's not something I'm particularly worried about. Do you use calcineurin inhibitors?
Yes, Dr. Portnoy, I widely use topical calcineurin inhibitors for patients. Firstly, I think one thing I wanted to mention on the slide here that says 0.03%. So currently it's actually only approved for patients who are ages 2 and above. 16 and above is when we can use the 0.1%. Now, people do use it in individuals who are younger than 2, but currently it's not technically approved for younger than 2. So yes, I've used both. both topical tacrolimus as well as topical pimecrolimus. And one benefit of this is that you don't have to give multiple like tubes of things to the patient. This one medication can be used all over the body. It can be used safely on the face in the intertriginous areas without, worrying about skin atrophy or anything like that. Now, this black box warning of malignancy, they've monitored once it's come out to the market, like very long-term studies, and they have not seen any increased risk of malignancy in these individuals who have, received the topical calcineurin inhibitors. I also find it a great medication because it's easy for the acute phase and then the maintenance phase, putting it on high-risk areas 1 to 2 times a week. Whereas topical steroids, you of course can do that, but got to be careful again on monitoring for HPA suppression. So yeah, those are my thoughts about these.
Yeah, but you definitely don't want to feed it to your pet rat. Yeah, I mean, I don't use these very often because when I get to a point where we're needing to use widespread calcineurin inhibitors because the patient's on all the steroids and not doing well, I'm usually thinking about a biologic like Dupixent. And health plans require a trial of a calcineurin inhibitor first before they will approve Dupixent, along with an EASI score greater than 21. So I have them try it in part as preparation for moving on to the next treatment. PDE4 inhibitors, that's phosphodiesterase 4. It's an enzyme that works in cells. The immune system kind of produces inflammatory cytokines, which can be reduced using an inhibitor. And so this Eucrisa is an ointment. It's available for adults and children 3 months and up. And have you ever used Eucrisa?
Absolutely. I have used it, successfully with patients, and it can be very helpful. Again, you prevent having to prescribe multiple steroids plus this to individuals. Now, I will say this is most effective, and it's also marketed for mild to moderate eczema. So generally moderate to severe. I generally don't use it for that subset of patients. And then secondly, this one is known to have burning as a side effect. And so that's something to counsel patients about as well.
Yeah, personally, I don't have a lot of experience prescribing Eucrisa. I just haven't gotten around to it for some reason. Okay, JAK inhibitors. The FDA has approved 3 JAK inhibitors for atopic dermatitis. There's, can you pronounce these things? I have no idea how they're pronounced. It's Sibin.
I think the first one is, abrocitinib.
It's easy for you to say.
Now, we don't use that particular one because we practice that largely a pediatric population, and this one's approved for adults.
With Reinbach is approved for children 12 and older with moderate to severe atopic dermatitis, and I actually have one patient on Reinbach. I didn't know about it. I haven't prescribed it. Patient came in and asked me about it, and I was like, wow, okay, I guess we could try it. So when the TV commercials say, ask your doctor about it, this person did that. And she's trying it. I don't know. She hasn't come back, so I don't know if it's working or not. And then Opzelura is for people 12 and older also. It's a cream JAK inhibitor. Have you ever used? I've never used this either. So do you have experience?
I haven't used this particular one. I know that we could in our individuals who are 12 to 18 who come to the clinic. Most of my patients have responded either with topical calcineurin or with dupilumab. And so I haven't gone to using this yet, but it's certainly something to keep in our arsenal if we needed it.
With asthma, they've done a really good job of defining which phenotypes would be best treated by different biologics. I don't really know when one would work better than another for atopic dermatitis. I don't know that phenotype characterization has been as clearly delineated, so it's hard to tell which one you would use and which one you wouldn't.
Right.
We do know that these work. I just thought I would throw in a few studies showing that Reinbach works better than placebo. And Sibinco, the Q-co.
Yeah, abrocitinib, yep.
It also works. There you go. Biologics. The FDA has approved 2 biologics to treat atopic dermatitis. There's There's Dupixent, dupilumab, and tralokinumab or Audrey. I don't know which is better. Clinical trials of them are not available, and I guarantee they never will be. Companies really don't want that. I've never prescribed Audrey. Is it something that's 18 and older, or something older people, or is it? I mean, I like Dupixent because it's now approved down to 6 months.
So I think, right,
Go
no,
ahead.
definitely. I think tralokinumab is, I believe, only for adults. So we haven't prescribed it, or it hasn't been used as much in our practice for that reason.
Yeah, I think we're pretty comfortable with dupilumab. Also, it treats asthma. It's now approved by the FDA for adults and children 6 months and up with moderate to severe atopic dermatitis. It blocks IL-4 and IL-13, two mediators that are involved in creating inflammation. It prevents them from binding to the receptors. It's approved for children with severe asthma too. If you have a patient who has severe eczema and severe asthma, it's a double header. It's a double hit. So that's an obvious choice. Dupixent is what I would recommend, and I listed the dosing below. And I know you've used Dupixent.
Yes, absolutely.
Isn't it great to use it? I mean, you have a patient who's got severe eczema, the parents are crying, their quality of life is destroyed, they're miserable, and you give them an injection of Dupixent. And I always tell them to come back in 4 weeks. Usually by 2 weeks, they're already clear. By 4 weeks, they come in and they're crying. They're so joyful and happy. And I have the nurses come in and we all just kind of celebrate this amazing miracle. Have you experienced that?
Yeah, I've had great success with this biologic, helping, clear up the skin. Also, remember this biologic is approved for EoE as well, in individuals who are 12 and above. So if you have coexisting atopic disorder as well, something to work with your GI doctors about, because it may help that as well.
Yeah, but the tears from the parents when their child's eczema is clear and their lives are back to normal.
I had a mom tell me once that after dupilumab, she could finally bathe her kid without her kid screaming, because the bath would physically hurt the child because the skin was so diseased. And she had this moment of tearing up in front of me because she could finally bathe her child without her child, crying. And so, yeah, it can result in some pretty dramatic improvements.
Yeah, I mean, it's such a miracle for me because we used to not have anything effective for eczema. Now we've got a wealth of riches. But Dupixent is such a miraculous drug. And by the way, I do not speak for the Dupixent company. I make no money from them. I don't think I've even been to a dinner that they've sponsored this year. So there's no conflict at all, except that I really love having parents come back and tell me what a miracle this is. It's just great. I don't know anything about Audrey. It's approved for 18 and older. So, of course, as a pediatric allergist, I would never use it. And you indicated you haven't given it to any of your adult patients?
No, I have not.
Okay. So I always give my patients with eczema a step plan. This is actually in our electronic medical record as a handout. The step plan tells them to bathe daily with a soaking bath, apply emollient to wet skin frequently during the day. Step 1, I give them a low potency topical steroid. Step 2, a medium potency steroid. Step 3, we haven't talked about this, but if there are infected areas, then they would use mupirocin. It's an antibiotic ointment. I also tell them about bleach baths and wet wraps if they need it. Usually I tell them about it and give them instructions and information, even if they don't need it, because someday they might need it. So it doesn't hurt to have them know about it. And then step up to another treatment if this doesn't work. If this doesn't work and their eczema is bad enough, and usually I can tell pretty fast, I do an easy score, make sure it's above 21. I immediately prescribe a calcineurin inhibitor, tell them to try it. And then I tell them that we should go ahead and apply for Dupixent. And I'm pretty fast to jump on that now because it can be life-saving, certainly life-sparing. It can make people's lives become more tolerable. What do you think about step plans?
Yeah, I think, because with atopic dermatitis, by the time they come to you, they may have seen multiple providers, have multiple, creams and tubes, etc. And they just get confused about what do I do when. So having a clear treatment plan outlined can be very helpful for these patients.
Absolutely, and it helps them to have it in writing. Make sure you write it down. So, after this, we're done. I would say enjoy treating eczema. In the past, before we had these more advanced treatments, eczema was not enjoyable to treat. Believe me, it was kind of a miserable experience. The parents were unhappy. Patients didn't do well. We were pretty limited in what we could do. Now, there's a lot we can do. And it's so gratifying to be able to offer these treatments. I didn't invent them, but I get credit, and it's even better. So, I don't know. Do you have any last words about eczema before we open it up to questions?
The last point that I wanted to make is, with your individuals with eczema, make sure that you have both a treatment plan as well as a maintenance plan to help prevent, flares of eczema, especially in those who are maybe not even on biologics. That's a known way to kind of avoid a lot of the frustrations that families come to you with and see good results in your kids. But I think we're ready to open it up to questions.
Exactly. So with that, we will open up we'll turn it back over to Dr. Miller, and you can lead the question session if there is one.
Okay, thanks for the great presentation here. I will advertise a little bit. In a few weeks, we'll have Dr. Mark Sirota talking about dermatology for the allergist. He's a former fellow in allergy with us, who also got fellowship training in dermatology. Just great talk. And then later in the year, we'll have a contact dermatitis presentation too. So more to come on COLA. We'll open for any questions from the audience.
I wondered if I could turn back to the possible allergic reasons for an exacerbation of atopic dermatitis. And I think it should be clear that it's not a cause. But first of all, foods. Do either of you seen instances in which a parent or an adult with atopic dermatitis comments that after a particular food, their disease seems to flare?
So, personally, yes. Food can trigger eczema. I guess we downplayed food because it's been so upplayed that we kind of went too far the other way. Food can trigger eczema. There's no question about it. And if you identify a food that is a major trigger of eczema, removing that food may help the eczema get much better. I have seen that, but it's not an IgE-mediated reaction. It's a type 4 reaction. Allergy testing does not help predict which foods will do that. And parents are demanding a test. There's no test. I do all these IgE tests, and a lot of them are positive, and then it's very confusing and doesn't help. The only way to tell if a food is actually causing or triggering the eczema is with an elimination diet for a week, and then a challenge where you take it away for a week and then add it back, one food at a time. Parents often are not willing to do that. It's a very tedious procedure. In some cases, they've already kind of dabbled in doing that. It really needs to be a strict elimination of a category of food, and then a challenge with a whole bunch of that food to see if there's a difference. If you don't notice a difference, then it can't be that food. That food is exonerated. I don't care what the IgE to the food is. I don't know. Have you seen that, Dr. Pandya?
Yeah, I have seen both foods and aeroallergens, exacerbate patients' eczema. And again, it's just important to tell them that it's a non-IgE mediated reaction. And then avoidance of that food, may result in improvement of the eczema. You also just want to make sure globally the eczema is kind of well controlled, either A, before re-challenging the food, or B, before going in an extensive food discussion, because that can lead you down a rabbit hole.
I don't know. What do you advise us to recommend, Dr. Slavin?
Well, I think that approach is very appropriate. And Dr. Pandya commented on the second part of my question, and that is inhalants. And I certainly anecdotally have seen, particularly with house dust, might
Yes.
a woman with atopic dermatitis who cleaned out her grandmother's attic and came in with head to toe exacerbation. And I've also seen instances, particularly in adults, with asthma, atopic dermatitis, and allergic rhinitis who did beautifully on immunotherapy, including the atopic dermatitis. So I'm glad you both commented on the possible allergic exacerbations or food and influence. Thank you.
Yeah.
Thank you. We did mention that in our immunotherapy talk last week that atopic dermatitis can be improved with it. And you're right, dust mite is one of the more common aeroallergens identified. In fact, if you culture affected skin, a lot of times you'll find a colonization of dust mites. It's another thing that bleach baths can help because they can eliminate dust mites from the skin. There's mites living in your skin. How gross is that? Well, one other thing that can be in your skin too is a fungus, especially malassezia has been associated with flares of eczema. I'm not suggesting going on ketoconazole, that can't be used for the scalp actually, ketoconazole for fungus, because a lot of times that's what's going on, but you can also use bleach bath for fungus as well.
And I think that brings up a really good point that especially if you have somebody who comes in who's just covered head to toe, they have vesicular lesions, et cetera, you want to make sure that those infections are thought about and evaluated for. We know that certain viruses can cause complications. We know that staph can cause complications. Valesia furfur, we know those can cause complications. So that's definitely something to think about in individuals wwho come in like that.
See, as usual, Dr. Slavin stimulated a long discussion.
I certainly share your feelings about dupilumab. I think we ought to emphasize the fact that the FDA approved it initially for atopic dermatitis, and then got around to asthma, allergic rhinitis.
Well, you were treating eczema before we had just about anything, weren't you?
Oh yes. We always had the steroids, but we always did our best to stay away from systemic steroids because at least it seemed as if when you stopped the steroids, the disease seemed to exacerbate more severely than it did before. So yeah, those were primitive days, Jay.
All right. Do we have any more questions from the audience? Okay, well, let's go ahead and take about a 3-minute break, be back around 11 o'clock, and we'll go for our next topic on food allergies.